Welcome to Raaonline. Today's topic is heart disease during pregnancy. So, what is the incidence of cardiovascular disease in pregnancy? It is around 0.5 to 1%, and most commonest cause of heart disease in pregnancy is rheumatic, and most commonest valve involved is the mitral valve. The other common cardiovascular diseases in pregnancy include the congenital heart disease or the hypertensive diseases. Maternal mortality related to cardiac disease has decreased remarkably over the past 50 years, and it has also led to a decrease in the maternal morbidity. So, the common cardiac diseases in pregnancy, if we were to enumerate, would be the rheumatic heart disease, the congenital heart disease, hypertensive heart disease, coronary artery disease, thyroid disorder, syphilitic disease, kyphoscoliotic cardiac disease, idiopathic cardiomyopathy, cor pulmonale, constructive pericarditis. It could be heart blocks or it could be isolated myocarditis. So, there is a wide spectrum of these disorders. What happens to the cardiac function as pregnancy advances? So, within the first 8 weeks of pregnancy, there is a changes start, and these changes maximize at 28 to 32 weeks of pregnancy. In a pregnant individual, there is a fall in the vascular resistance with the advance of pregnancy. The patient blood pressure falls because of the fall in the systemic vascular resistance. There is an increase in the heart rate and increase in the blood volume as the pregnancy is advancing. Now, all these changes lead to an increase in the stroke volume, and the cardiac output increases by 30 to 50% in a pregnant individual. Now, there is also a maternal weight gain and a rise in the basal metabolic rate which happens during pregnancy, and these physiological changes of pregnancy also affect the cardiac output. Now, cardiac output is very high in pregnant women when she is in a lateral recumbent position as compared to when she is in a supine position. So, these changes are significant because the gravid uterus in supine position compresses the IVC and reduces the end diastolic volume. During labor, the cardiac output will increase moderately in the first stage of labor, and the cardiac output is maximum in the second stage of labor. And even in the immediate postpartum period, when there is cutoff of the fetovascular circulation after the delivery of placenta, and there is sequestration of blood into the maternal circulation from the uterine sinuses, there is again a rise in the cardiac output in the immediate postpartum period. So, these are the times when the patient can have a cardiac failure. So, cardiac changes start at around 8 weeks, maximize at around 28 to 32 weeks. There is a stress on the heart in the first stage, more so in the second stage of labor, and there is a chance of cardiac failure even in the postpartum after the delivery of the baby. So, what happens in normal pregnancy? So, in a normal pregnancy, because of the rise in the diaphragm, the heart is displaced upwards and to the left with a lateral rotation along its long axis. The resting pulse rate in pregnancy is higher by around 10 beats per minute, and there are some changes in the heart sounds which include an exaggerated splitting of the first heart sound, which an increase in the loudness of both the components of the first heart sound, and there is no definitive changes in the aortic and pulmonary elements in the second stave, and there is an easily heard third heart sound. Now, in pregnancy, grade 1 and grade 2 systolic murmurs are heard in 90% of normal individuals. Sometimes there can be a continuous murmur arising from the breast vasculature in 10% of cases because of the increased blood flow in the internal mammary artery. And if there is a grade 1 or grade 2 murmur, it can be a physiological pregnancy related murmur, but a grade 3 or a grade 4 murmur is always pathological. So, why there is a murmur in pregnancy is because of the rise in the plasma volume during pregnancy. So, as the gestational age is advancing with the increase in the lunar months of pregnancy, so there is an increase in the plasma volume which is maximum at around 32 weeks of pregnancy. So, at 32 weeks of pregnancy, the volume is the maximum. And this is a graph which showing the rise in the cardiac output, the stroke volume and the heart rate in a pregnant individual with a rise in the gestational age. So as the gestational age is advancing, there is a rise in the stroke volume, there is an increase in the heart rate, and consequently there is an increase in the cardiac output. In a person who is lying down supine, there is a different readings, because in the supine position the gravid uterus presses upon the inferior vena cava, the end diastolic volume is less, and so the cardiac output is less. So in the supine position, the patient has got these changes in the cardiac output and the stroke volume. Now after the delivery, in the first stage of labor, again there is a rise in the cardiac output. The second stage of labor, the cardiac output is high. Immediately in the postpartum period, the cardiac output is maximum, and in the 6 to 8 weeks following the delivery of the baby, the cardiac output returns to normal. Now during pregnancy, there is an increase in blood volume, heart rate, pulse pressure, cardiac output, and a reduction in the peripheral resistance and blood pressure. There is an increase in heart rate and stroke volume. The burden on the maternal heart starts by around 8 weeks and reaches a peak by around 28 to 32 weeks. And other high risk periods when there is a chance of precipitation of cardiac failure is immediately after delivery and 1 week postpartum.